Really, it's really such an honor and privilege to be here with all of you, to be with this panel. I'd like to frame a couple comments around purpose and power and the relationship between the two of them. Walking in today, Vikas found me and he said, no need for heavy lifting, just speak your truth. So here goes. I was a medical student when someone told me something that really changed my life. I was sitting in an audience of about 100 students over at the Harvard School of Public Health in the Kresge Auditorium, and the speaker was Jim Kim, who, as many of you know, is the co-founder of Partners in Health. He's the current president of the World Bank. And at one moment in his talk, he looked up, and I swear he looked at all 100 of us right in the eyes, though of course that's not possible. And he said this. He said, optimism is a moral choice. Optimism is a moral choice, but good intentions are not enough. We have to learn how to deliver. So when Partners in Health began their work in Haiti, they had no reason to believe that they would be successful, that they would change our understanding globally of the dignity in healthcare that's deliverable to the poorest people in the most difficult conditions, that they would inspire a generation to follow in their footsteps. They had no idea that that would happen. But they did know that they had to do it, that it was the right thing to do, that they would walk into that jungle with a commitment to make the road by walking. And by doing so, they could stick to it, and they succeeded. And what it meant for me to hear those words, optimism is a moral choice, it told me that there was a possibility that in the future, my life might be undivided, that what I did and what was most meaningful to me might be one, that I could work alongside colleagues who felt that way, who were animated by that common cause, and that my work might one day be meaningful. And those words carried me through medical school, residency. I went to work for Partners in Health in Rwanda when I finished training. I learned about health systems and helping them work better for vulnerable communities under difficult conditions. I watched leaders make really difficult decisions, painful choices with limited resources about how and where to spend. But they did so factoring hope and dignity always. People and the impact of these choices on their lives was always central in the room. I had the opportunity to start a residency program at Mass General Hospital called the Global Primary Care Program, which tried to teach these lessons I had learned in Rwanda to a generation that was hungry for them, and help them see that these were universal lessons. These are principles that didn't apply just in Rwanda, but could be applicable here, that they might actually be part of the key to our being able to move lessons and optimism between settings, anchoring this generation. When we put this residency out in the National Residency Matching Program for the first time with really no chance to market it, no chance to really do all the invitations that we should have, we were astounded to find that more than 600 applicants applied from 86 countries for just 2 spots, making it one of the most competitive residencies in the country in its first year. And what they said sounded a lot like what I felt in my own heart, that this is not about a place in the world. This is about health equity. It's about social justice. It's about health as a human right. It's about broken health systems. It's about a way to make that better. And they wanted that training. They wanted to do that. And I think that was just the tip of the iceberg. What I really wanted to communicate is that I think there is a rising tide of optimism, pragmatic optimism that wants to deliver and not just have good intentions. And it's all around us. And there is a movement already. If the need to challenge unfettered capitalism with public demand and public debate, as Diane Meyer invited us to consider, is there. If the dream of imagining the profession speaking with one voice, as Don Bowick invited us to consider, is there, then we need to not only build a movement, we need to make common cause with an existing movement that has been underway for over a decade. Many of you are aware of what that movement has achieved, but I'll just mention 2 of the outcomes that really stick in my mind. So today, in pretty much any country in the world, and at a price that the poorest people can afford, life-saving treatment for HIV is available. almost anyone could get that treatment in any country of the world. Nearly every medical school in the US has been responding to this surge in demand. The number of global health programs has tripled over a 3 to 4 year period. Programs are either in place or in development. This demand is driving a transformation across medical education. There's a disconnect between what is visible, I think, for those of us working on the right care movement domestically and globally. And we don't need to look for that army there amongst us. But the question is, how do we bring them together? When I was in rural Liberia with a colleague and we were implementing a mental health program deep in a rainforest about 12 hours from the nearest city, we would often reflect on what it would take to make this vision of just and fair care possible across the country. And we would tell ourselves that we need to master 2 languages to affect that kind of change: the language of love and the language of power. And we really saw those as 2 separate languages, but it was later when I was sitting in a classroom in the Kennedy School listening to Marshall Gann's talk about the intelligence behind his organizing strategy. And he defined power this way. He said, "Power is when your need for my resources is greater than my need for your resources." An extreme example of that: if your need not to be embarrassed on international TV as a leader of a government is greater than my need for food and life itself, I can starve myself in a hunger strike on national TV and make you act. A less extreme example, just down the street again at Harvard Medical School, there was a moment where the dean of our medical school defunded a small and relatively unknown primary care working group. But someone named Andrew Morse Singer, who had his background in community organizing in the gay and lesbian rights movement, recognized the opportunity. And he galvanized a movement around this, a series of town halls, an uproar across the primary care community, and a generous and forward-looking donor came forward, and a $35 million Center for Primary Care was founded at Harvard Medical School, which will possibly be the lasting legacy of this dean, when that may not have been his initial intention. And to his great credit, I think he has embraced it. He has really seen the possibility and has been behind it every step of the way. But this is how the ripple begins, I think. The language of love and the language of power may not be separate languages, but the same. They require us to make a promise to the generation that wants to believe that optimism is a moral choice, to help them believe that that can be their future, that they can work meaningfully alongside us here in the US, that we can engage the leadership and the structures and the existing bodies that are already there around us for global health, and make it about global health truly, where we are on the globe and these problems are universal. And perhaps the biggest opportunity in global health today is to take this time-limited window that we have with the Affordable Care Act, this modest financial reform, and create tremendous, deep, and lasting transformation in the delivery system, in what we think of as care itself, who it engages, who is driving that care, which parts of our sectors it covers, and that will ripple forward in history, that will ripple out to the world, and that will change the nature of health all around the world. So, optimism, we should harness it. Thank you.
Wow. What a wonderful